Thanks, everybody. Good morning, everybody. Welcome to Tamworth and welcome to the fourth hearing of the committee's inquiry into fertility support and assisted reproductive treatment. I'd like to begin by acknowledging the Kamilaroi and Gomeroi peoples of the Kamilaroi Nation, the traditional custodians of the land on which we're meeting today, and pay my respects to elders past and present and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I also acknowledge and pay my respects to any Aboriginal and Torres Strait Islander people who are joining us here today. My name is Sarah Mitchell and I'm the chair of the committee. Could I ask everybody in the room to please turn their mobile phones to silent? Parliamentary privilege applies to witnesses in relation to the evidence they give today. However, it does not apply to what witnesses may say outside of the hearing. Therefore, I urge witnesses to be careful about making comments to the media or to others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants, and I encourage committee members and witnesses to be mindful of these procedures. So welcome to our first witnesses. Thank you both for being here with the committee today and making the time to give evidence and share your experiences with us. Could I ask each of you just to state your name and swear either an oath or an affirmation? And I'll start with you, please, Ms. Fletcher.
Sophie Fletcher. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Mrs. Smith?
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Excellent. Thank you so much. So there's an opportunity for both of you to make an opening statement for the committee. So I might start again with you, Mrs. Fletcher.
My name is Sophie Fletcher. I am a farmer, small business owner and a mother living in Walker and regional New South Wales. I am here today not just to share my story, but to highlight the reality of accessing maternity and fertility care in rural Australia. My first child was born in 2020 in the midst of COVID border lockdowns. At 34 weeks pregnant, I had no certainty about where I would give birth, despite already having paid for private care in Queensland. When my waters broke at 36 weeks, I arrived at Tamworth Hospital with no records, no plan, and very little support. What followed was not just a difficult birth, but a system that felt disjointed, underprepared, and at times lacking in basic dignity of care. Since then, my husband and I have been trying to grow our family. This journey has been marked by secondary infertility and years of long-distance travel, often alone, for appointments that could have been managed remotely. This has come at a significant emotional and financial cost to my family. I have coordinated my own care, transferred my own medical records, and sourced my own support services. After 6 failed embryo transfers, I sought a second opinion and was diagnosed with stage 4 endometriosis that had previously been missed. With my new specialist, I'm now travelling up to 6.5 hours each way for specialised care. Since engaging with her, we've had another 7 embryo transfers, and within that, I've experienced 3 miscarriages, the birth of my son Thomas from embryo number 9, 2 failed transfers, and I am currently 15 weeks pregnant from embryo 13. So that is 13 embryo transfers with 1 baby at home and hopefully another one come November. Amongst that, we have travelled that distance for not only our embryo transfers, but for egg collections, D&Cs and endometriosis excision surgeries. At no point was I offered coordinated wraparound care. The burden of navigating the system sat entirely with me. Since sharing my story, I have become someone in our community at home and online that people now use as a support tool and to ask me the questions due to the lack of resources. My experience is not unique. It reflects a broader pattern of inequity where rural women face increased risk, reduced access, and a level of personal responsibility that would not be expected in metropolitan settings. I'm here to advocate for a system that is more connected, more proactive, and more equitable, because no woman should have to manage this level of complexity alone. On a grassroots level, and as someone still navigating the system daily, I strongly recommend the committee to look at reliability and availability of services in rural communities. Adequate funding for travel and accommodation for those having to travel for specialised care, along with funding for rural communities and rural organisations trying to make a difference. Thank you.
Thank you. Mrs. Smith?
Okay.
Thank you for the opportunity to appear today and for your consideration of our original submission and recommendations. My husband Dylan sends his apologies for not being here today. He's supervising 2 placement students as a teacher at his school. He would welcome any direct questions you would like to pose to him as part of our joint submission. We live near Armidale in regional New South Wales and are parents to 1 son through IVF. We continue to navigate fertility treatment in the hope of building our family. Since our original submission, we have continued to navigate further complications and barriers to our treatment journey. So today, I do bring you an addendum to our submission that covers further expansion on our original submission, as well as new barriers and experiences encountered. We hope you can consider the addendum as part of the inquiry, as experience in both the original and addendum speaks particularly to the inquiry's terms of reference. Over several years, we have navigated both private and bulk billed IVF systems, as well as metropolitan and regional monitoring pathways. I've also received an endometriosis diagnosis and an adenomyosis diagnosis, pregnancy complications, birth trauma, postpartum complications with breastfeeding and pelvic floor dysfunction, miscarriages, ovarian hyperstimulation syndrome, with an ICU hospitalisation in Tamworth, and ongoing fertility treatment. We have navigated 4 different IVF specialists in 3 cities across 4 different providers. Through that process, we've repeatedly encountered systemic barriers associated with being regional patients. These barriers include delayed pathology turnaround times, significantly affecting cycle management, extensive travel requirements, fragmented coordination between clinics and local healthcare providers, prolonged emergency department presentations for pregnancy complications and losses, significant out-of-pocket costs, despite having private health insurance at the gold level, Medicare and IPTAS support. And we have experienced ongoing pressures on employment leave balances and family logistics. We've also experienced repeated fragmentation of care from fertility treatment to early pregnancy care, which is prior to being able to access a midwifery care after 20 weeks, to miscarriage management, to maternity care and postnatal recovery. This is despite us as patients experiencing these as one continuous journey. Once pregnancy was achieved, responsibility often shifted rapidly back onto local GPs, with limited handover documentation provided to them. This often left us and our local providers, emergency departments, and later midwifery services navigating pregnancy complications and losses without coordinated pathways or continuity of care. I want to emphasise that individual clinicians, nurses, sonographers, and GPs were caring and doing their best with these difficult fragmented systems. Our concerns are primarily about fragmentation and structural gaps rather than those individual staff members dropping the ball. We are very fortunate to have stable employment, supportive workplaces, health literacy, family support, and leave entitlements. Yet even for us, the cumulative emotional, logistical and financial burden has been enormous. I'm here today because many regional families face these same barriers with far fewer resources and supports available to them. Regional families should not have to overcome additional barriers simply because of where we live. Thank you. Welcome questions.
Thank you both very much for sharing those stories. And I think I would speak on behalf of all of the committee when, firstly, we say sorry to both of you for the losses that you've been through, but also for being brave enough to come here and share today. I think it's going to make a real difference to the work of the committee, and we really appreciate you being so honest and open with us. And if in answering questions you do need to take a minute, or we've got plenty of time, so don't feel sort of pressure if you need to take a second to respond, that's fine. So the committee has resolved that we'll just do sort of free-flowing questions. So it's a very formal setup, but we just wanted to have a chat to you about, sort of what you've been through, but also more importantly, I think what we could maybe recommend to make the journey a little bit easier from your experiences. So I might just start with a couple and then I'll throw to my colleagues. But interesting that for both of you, obviously the fact that you've got to travel to access the IVF services. I think, Kira, you said you've been to Newcastle for your IVF. Is that right?
That was we started our journey in Port Macquarie.
Okay.
And they closed the Janaea outreach service there. So Newcastle was our first IVF treatment.
Yeah. Okay.
And we've since had to travel to Sydney for bulk build clinics.
Yeah.
And a follow-on clinic to get access to PGTA testing.
Okay. And then for you, Sophie, do you go the Gold Coast? Okay. Yeah. And so that's how long a journey from Walcott?
6.5 hours.
Yeah. And how often do you need to be heading up there for your appointments and things when you're in that sort of stage of?
Oh, every couple of weeks.
Yeah. Okay.
Depending.
Yeah. And if you had, I guess, the opportunity for those sort of services closer to home, maybe in Armidale or here in Tamworth, what kind of difference would that make for you and your families if you could access?
Huge difference. Because even you talked about blood collections. That's one of the biggest letdowns, because there's no, from my experience, reliability of service for me being open. You can say on the website that they're open, but I can turn up there and they're not, and I'm having to travel to Tamworth to get a blood test.
Okay. So
and even then you're not guaranteed same day.
Yeah, and that's
results.
Important.
Very important.
Yeah. So perhaps a potential recommendation from the committee, along with looking for more sort of public clinics or just clinics in general in regional communities, that pathology piece is also an important
Huge
part.
staff.
Yeah.
And it's nothing against them, but they just don't have the staff to cover those shifts.
Yeah. Is that your experience as well, Kira?
Yeah, I think pathology is, the same day turnaround is one of the biggest things I've highlighted, especially in my addendum. I'm not saying I got ovarian hyperstimulation because of a delay, but my stimulation medication was based on a 24-hour delay. Perhaps if I got same-day results, it wouldn't have led to that, and I wouldn't have ended up in ICU in Tamworth as a result of that.
Yeah.
That same-day turnaround is wonderful if you can get it. I've seen it work. Back when I was with Janaea, they would take us through Armidale Hospital pathology, and they used to be able to do the bloods in Tamworth for the hormone levels, and they would be same day. Working with other providers in Sydney, they have to go through liability or a DHM, and they send those bloods, no matter how early you get them in the morning in Armidale, to Tamworth, and then they get on a plane and go to Sydney and they test them there. It's always outside hours. So you will not get the same day results. I'm not saying bring the monitoring services to Armidale. It would just be nice if there was some sort of way we could get those bloods as same day. I think it would help a lot if it was there. A lot of my embryos were frozen on day one, and there is a problem with lining that up with ovulation because they need to be defrosted right after ovulation.
Yeah.
So we've had experiences where the bloods have been delayed and not come in until late the following morning. And we've missed the chance to do that defrost and grow them out, and that's a cancelled cycle. So it seems simple. It's okay. Oh, we'll just get them the next day, but it does have flow-on effects.
Yeah. And I think that's, again, we've had witnesses on other days talk about their lived experience in metro areas, but I think that's just another hurdle that regional families and women like you have to manage as well when you've got that issue of access to pathology, which is different to what happens in the city.
For my first 6 transfers, I was driving 5 hours for a guaranteed same-day blood test result.
Yeah.
To get that, because we were so dependent on that. And that was, same day. I was driving up and back in the same day.
So a 10-hour round trip. Yeah, right.
Yeah.
Wow. Yeah, please. Yeah.
You mentioned when you were going through another provider and they used Armidale Hospital, they were able to do that same day turnaround via Tamworth.
That has since changed. Tamworth no longer can do that. They're too overloaded. That's what I have been told by one of the Armidale.
Sure. So
pathology
there
labs.
was the capacity to do it in the public clinic, but when we're using DHM and liability, they've got to fly it to a centralised lab. Is that?
Yes, in Sydney.
I'm trying to understand what the differences might
that's
be
okay.
from a practical perspective if we're, to make a recommendation, because it sounds like there are the lab services, some like in Tamworth, for example, within the public system, but it also, it may be the case that, since your experience, as you say, they are now at capacity. So is there something specific that you think we could suggest or recommend? Because I'm just mindful that we'll have limited capacity to impact or change, say, the likes of DHM and liability in terms of directing what whether they can set up a lab in Tamworth or not. But yeah, from that practical perspective.
So with the public hospital pathology, they can't guarantee it either because they might have emergencies and other things going on.
Right.
So they used to be able to guarantee it in 2023 when I was going through treatment with the Newcastle company. They would get it same day.
Yeah.
Since then, with my other clinics, including the public provider in Western Sydney, they can't use the hospital service because it's the public service. So if I wanted to use that, I have to pay out of pocket. I get a bill and I pay for it to try to guarantee same day. But even then, they can't guarantee same day through the hospital provider because they can become overloaded at the Tamworth location and not get them same day. So that's probably a resourcing issue on the public system as well on getting their lab. So they are capable of doing it, but whether they can get it on the same day because of the load issue. DHM and liability, regardless, will send them to Sydney after they get to Tamworth. So if I drove to Tamworth, it would get on an earlier plane to go to Sydney. But if I'm in Armidale getting my pathology, it has to then wait until something like 10 a.m. and then it comes to Tamworth, then gets on a plane and goes to Sydney.
I mean, the fact that you know all this speaks volumes as to
A lot of trial and error has gone into knowing.
Oh,
this.
yeah, lots of trial and error.
All of this.
Yeah.
Lots of little quirks that you find out as you're going through this, and unfortunately you find out when something goes wrong.
Yeah. Yeah. I'll just let Dr. Con.
Thanks, Chair. I wanted to follow up some of the questions you've already answered about travel and specifically ask about IPTAS, the Isolated Patients Travel and Accommodation Assistance. You're nodding effusively.
Oh, yeah, no, I definitely use that.
Are there changes that you would recommend to IPTAS to make it more helpful to support you when you've had to make those trips?
More money per night accommodation. I think they're only it's $80 a night they cover. And when you're trying to get accommodation on the Gold Coast, you can't get much for under $300 a night. And when you have to be there for sometimes a week at a time, and they don't cover Airbnbs. Well, they do, but it's a different amount, again, that they will cover from that. And then it's a certain amount per kilometre. And given the state of diesel at the moment, it doesn't really cover a lot for us.
Yeah, absolutely. So
So
for someone
increased.
who's in maybe a difficult financial circumstance to you and your family, that IPTAS reimbursement, it sounds like it's not actually covering the
look, it
real
helps.
cost of that travel.
No, it does not cover the cost at all. And I mean, it's nice, but you're still out of pocket a lot.
Definitely. I think something that can be changed in the guidelines is something I've encountered when I've had to take my son over to Port Macquarie, where our only care is for his family. So we're about 6.5 hours from our provider. So we have to go to Port Macquarie to drop him off. So that's day one. Then we go from there to Sydney for the treatment. Then we come back to Port Macquarie and then we come back home. But the guidelines for IPTAS say that you have to take the most direct route.
Yeah.
I'm saying, don't pay me to go to Port Macquarie, fair enough, but give me the reimbursement for the direct route. I have encountered that problem with them. They have granted me one of those as a direct route, but the guidelines are very grey in that area, and I think it would help them to be able to apply the correct amount and basically give people more flexibility when they have no other options. I can't take the direct route.
Yeah.
I'm not allowed to take my child into a clean room where I'm getting an embryo transfer. And is it fair that I leave my husband and my son at home when I need that emotional support from my husband to come in with me as well? And certainly when I'm going for an egg retrieval, he has to be there. He has to pick me up. So what do we do with our son? Even if we could take him down, we can't bring him to the hospital for these services.
Thank you. It's really helpful. And I think you've led into the next question I wanted to ask. Kira, you wrote about the experiences of your partner and your son in your written submission. And I wanted to ask both of you, I mean, obviously the journey you've been on with your fertility doesn't just impact you, it's obviously impacted your whole family. What would you recommend we consider in terms of what's needed for partners, for children, for the rest of the family?
You can also take it on notice and make your husband answer. You could do that.
Yeah.
I think you were asking what policies could be changed as well, and I think I've put in the addendum, or my husband put it in the addendum, the trouble he's had getting leave allowances through his employer, where it's not allowing him to access his fertility treatment leave because he is not the intended birthing parent. He was told that you're not the one going through treatment. He is. This is a two-person situation that we're in. It may not be for everyone, but we're doing this together, and it's bizarre to me that that can't be something he can access. It does mean that I end up with a lot of that burden, a lot of that load, the emotional load around it, and he's had to take other kinds of leave that eats into our personal time. Is that fair? He said that that would help a lot if that sort of thing was changed. And I guess, just to my son, we take him out of daycare, we take him to the grandparents' house for care. That obviously affects him as well. I'm not saying there's anything we can change in that area. That's just how it impacts him as well. We can take a whole week off of daycare and work just to be able to go for treatment.
You're still paying for that daycare. You're still paying for that.
Yeah, you do. Yeah.
Is it sort of similar, I guess, for you too in your family?
Well, not in regards to leave. We're self-employed.
Yeah.
So there is no leave option. So that is why most of the time I do my treatments by myself because we just can't have both of us off farm.
Yeah.
And my eldest son is now at school. So taking him out of school is not ideal. So one of us does stay at home most of the time. Well, one of us, him, stays at home because I can't.
Yeah. Is it, and I don't want you to answer if you're not comfortable, but like in terms of how much personally this journey so far sort of has cost you financially, let alone the emotional side of things. But I mean, are there sort of ballpark figures of how much you think?
Well, it's $4,500 a transfer.
Yeah.
And it's $14,000 for me for an egg collection.
Yeah, right.
And then there's hospital excess every time you go in. I don't really want to think about the actual figure, but it'd be close to or over 100,000 for us easily. That's travel, accommodation, time off farm, time out of our business we had at the start of this, and with wages covering staff for me to have time off. Yeah, huge, huge.
Yeah, I just I should have was remiss of me not to mention before, but one of our committee members, Emma Hurst, is online, so you'll see her up on the screen. She's got a couple of questions, so I might go to her now.
Thanks, Chair, and thank you both for coming today. And I'm really sorry I couldn't be there in person. This question's for both of you, but I will refer to Kira, your submission, because you mentioned midwifery continuity of care, particularly in your submission. And we did another inquiry into birth trauma in New South Wales, and that was something that continually came up. I just wanted to get a better understanding in regards to the benefit of midwifery continuity of care for people undergoing IVF and for other fertility treatments. And then on top of that, why it's so important, particularly and specifically for families in regional and remote areas in New South Wales.
That's a really big question.
Yes, sorry.
Why is it so important to me, I suppose, is how I can answer this. And maybe that will help in some way. I didn't see a midwife with my firstborn until I was 18 weeks pregnant. I had 2 significant bleeds where I presented to ED in that pregnancy. I had a GP at the time as well, she was not a GP gynae, just GP. I had to navigate that through the emergency department. I didn't have any access to mental health support at the time, and I was kind of left floundering with what to do. Thankfully, I did get my son in the end, but I think I was very stoic throughout the pregnancy, very disconnected because of those bleeds, because of how much had gone wrong with IVF before that. I just didn't think anything was going to work. And then when I did get to see the midwives at 18, 20 weeks, they didn't know any of this. It just seemed like I was presenting as, oh, you're going to be a mum, and I was very good at masking. And they do talk about this a lot in mental health support now that I access that after I realised that I was not coping. I met a different midwife every appointment. I had a different midwife for my birth. There was nothing we could really discuss besides taking a blood pressure, doing a fundal height measurement at any of those appointments. They weren't long enough. There was nothing we could really capture to put my mind at ease going into the birth, and maybe trauma in that birth could have been avoided if I had people who I knew and time to have these conversations, and that they knew my background into this. This was not just a pregnancy that had a couple of bleeds and that's the only reason I'm stressed. This was significant, going on for years before I even got there, to see these different midwives each time. I'm not really sure whether that helps you with the question you were asking.
I think it does. It's like, because you've gone through such a long IVF and fertility journey, that when you're coming into a hospital and the health professionals aren't aware of that background, it makes the whole process more difficult and more disconnected. Is that what am I correct in that sort of summary?
Yeah, essentially, yes. I did feel very disconnected during that process, especially with meeting a new person every time and almost having to explain myself each time. But then there's not enough time to explain yourself and that entire history that you have that does lead to your experience during your pregnancy and birth. I don't really know the fix to that, but it would be nice to be able to see public midwives a lot earlier in that process and to have something well documented before going into that, so that everyone does have your story at the very least, even if you can't have continuity of care with one provider or a couple of providers together in a group practice.
Thank you. Sophie, did you have anything that you wanted to add to that in regards to your experience as a regional and rural family, or having that continuity of care in regards to the fertility journey itself?
I go privately, so I do see the same midwife from start to finish. She's not there at the birth, but she's a part of my specialist's clinic. So she works closely with my OB. So for that reason, I chose to go privately.
And so you found that having that continuity was of extreme benefit, I'm
Absolutely.
guessing, compared to, yeah.
Oh, absolutely, because I speak to her every 4 weeks. It's all on telehealth. I'm able to do a lot or most of my appointments over the phone because I share care with my GP, with my specialist, with my OB. And every 4 weeks I have a check-in with my midwife, and she has everything in front of her that I've been through. And she's well aware of where we live, and that's a big factor in our appointments because there's a lot of planning.
Yeah, thank you. Thank you. Thanks to both of you for sharing that. And I think it's really useful for the committee to hear the two differences with those stories as well, and the support for that journey as well. Thank you, Chair.
Thanks. I think we'll go to Ms. Carter.
Thank you both for being here. Kira, if I could ask you, I'm really interested in your submission when you were, and it follows on really from the continuity of care issue, this segmentation between the fertility clinic and getting pregnant, and then it feels like from the submission, job done, you're on your own. Could you talk about that a little bit?
It's certainly what it felt like.
Yeah.
In a lot of the cases. And I get it, that is their business to get you pregnant. And maybe if it's in a metro area, then some of those specialists who I was seeing are also OBs. So you can then transition from the IVF clinic with the same provider you have, just as their OB component. With my first provider, we were given sort of given a document that just said, we recommend this obstetrician in Port Macquarie. I don't live in Port Macquarie. Yes, we do have family there. We didn't have any private obstetricians in Armidale with my first. We have one GP obstetrician now, or maybe two, but only one who does the hospital service of birthing. And with my other two providers in Sydney, I haven't had I've had successful pregnancies with one of those providers in Sydney and then later lost them, but they were unable to help with any of that process right after a home pregnancy test or an early blood test. I rang them going, I think I'm having a miscarriage. What do I do? Go see your GP, go see the hospital. Just that continuity and the lack of handover there, I get that they can't necessarily do that service for you, but where is the documentation that goes back to your GP? It's absent in 3 of the 4 providers I've used. Things are just not getting back to my GP and then on to the hospital. It's not done well.
So would it help if IVF clinics were encouraged to focus on birth rather than simply pregnancy?
I would say no, because I would still like to birth in my community. And I understand that they are very specialised. I will go to the city for that specialised service, but I would still like the opportunity to see midwives in my community if I'm able to. If I have a high-risk pregnancy, obviously it's not an option, but I would like to have that chance. So I think what I'm saying is, if you're going to get me pregnant, at the very least, provide a decent synopsis and potential recommendations of the risk factors that I have back to my GP or care provider in the country.
Sorry, does yours
that-
not provide that?
Only one has. Yeah, only one.
So,
And that has worked better with that one.
yeah.
It has.
So Sophie, you talked about using shared care for the pregnancy. Is there a sort of a shared care IVF model that's available for sort of regional women using, Sydney or Gold Coast based IVF clinics?
Not
Rural
really.
monitoring's a thing where you can get rural ultrasounds and your rural pathology without having to go all the way to the city.
Yeah.
But
But
I don't know of
even
any.
no, there's not really a shared care model. It's basically up to us to, if we want to do things locally, to take that risk and do it ourselves.
Would is a shared care model something that we could usefully explore? Would it work in the context of IVF the way it works in pregnancy, or?
I don't think so.
You might need more providers, really,
Yeah.
who are willing to,
Mm.
or who have the ability, I suppose. As I said, we've only got one GP obstetrician in Armidale, maybe two.
Mm.
But even one of my ultrasounds for my egg collections,
Mm.
I don't think the sonographer knew what she was doing and therefore didn't send through the correct photos and dimensions of everything, which then affected my collection.
Mm.
So if I'd had the ultrasound done in my specialist's rooms, she would have prolonged my medication for a few more days to let follicles grow out to eggs. And because she didn't have that information, she booked in a collection and therefore I missed the opportunity to have more eggs collected. And that was done in Tamworth, and it's a training thing, I think. Lack of training in current.
I think preferred providers would help.
Sorry, what do you mean by preferred providers?
If your clinic is going to deal with you and you live in Armidale or Walker, you should have a preferred provider, surely within 100 kilometres, that you can say, this is our preferred provider, who knows what they're doing in this situation. We want you to use them because we are going to guarantee that, they're going to get done what we need done. It's sort of how the pathology model works. They do generally have a preferred provider. But again, it's not same day.
I've never experienced preferred providers with pathology.
Yeah, okay.
And I go through Monash. Never experienced.
And should there be preferred providers for after pregnancy care, for want of a better term?
Yeah,
that to continue through to the birth and continue support.
I would appreciate that. I think sometimes we don't always have that because we don't have the providers in the country. But I've selected a GP gynecologist in Armidale this time. I am 15 weeks pregnant and the continuity of care there has been better because my latest provider has sent all that documentation back. And they did not discharge me right after pregnancy. They did another appointment. They organised my NIP to my nuchal. They waited for those results to come back and then discharged me to a GP obstetrician, not just my GP. If they knew how wonderful he was, I think that they would choose him as a preferred provider. Maybe that's how to do it. If they did find those people. And with my first clinic, they tried, as I said, they selected someone in Port Macquarie, but that's a long way to go from Armidale. That's 3.5 hours or so. But helpful that they tried.
Yes. Yeah. Thank you. Thank you both. Thank you.
Emily or Greg, do you have any?
I've got it.
Yeah, sure. Yeah.
If that's all right. Kira, I just wanted to ask you about in your initial submission. I know you sort of expanded in the addendum some of the impact of the day one freezing. If you're comfortable with sharing, it struck me as being, it's obviously mentioned in your original, but then again in your addendum. Was it explained to you why that needed to occur and what was the rationale, if you like?
Yeah, so it is in their policy documents, I suppose, and the rationale behind it is to do with research. It's research-based.
Okay.
Some women cannot grow, some couples cannot grow an embryo to day 5. They start to deteriorate. So it might be better to transfer them at day 2 or 3. In a freeze-all cycle where you've been overstimulated or you're just too unwell to have a transfer or you're going to get testing done on those embryos, their policy is they will freeze them all on day 1 so that then they can defrost them in batches of 4 at a time, grow them out to day 5. As I was saying earlier, you have to defrost them right after you ovulate. So that has to be timed. You have to catch that. That grace is only 1 day. So there is research to say that, yes, I suppose some women will need a day 2 or day 3 transfer, but that policy is incredibly rigid. As I said, I had a proven cycle of getting to day 5 with at least 3 embryos. Why? And I don't think they understood the ramifications for someone in a rural setting with that pathology delay as well. Yeah, that's a constant problem. Every month we do a transfer, every single time, lining all that up.
And so, to your understanding, is it that there is a lack of available research to support, there being additional flexibility, or is it?
I think it's just a hard line that they take.
Okay. Is this all providers?
No, this is the only provider I know of in Australia that does this.
And that's the current.
I have never heard
Westmead
of it
fertility.
It is Westmead.
Yeah.
As I said, there's logic behind it, but why is that so rigid on someone with a proven day 5 or day 5 embryos? Yeah.
And so there was no ability for you to have any say in
I
that?
had no say in saying, well, why can't I just have them to day 5? It's like, sorry, you will not have a fresh transfer because your levels are too high. So I was at risk of the hyperstimulation, which I did get. So it's good that they did not do a fresh transfer. It could have been exceptionally dangerous. But there was no option there. They will freeze. If they cannot do a fresh transfer, they will freeze on day 1. Because they do have the logic there of, we'll take 4 and defrost 4 at a time. If one gets to day 5, we'll do a transfer from that 4. That's also led to bigger problems. I produce a lot of eggs. So we had 35 eggs collected in that particular round. And 28, I think, were able to fertilise. That's a lot of defrost batches. Yes, most of those batches we've defrosted have gotten at least 1 to day 5. But what if they didn't? We end up in Sydney waiting for that day 5 one to be able to transfer for no good reason, when they could have defrosted or could have grown out the whole 28 to know exactly which one was going to get to day 5 first, look the strongest, be ready for transfer. I think it has contributed a lot to repeated failed transfers.
I'm sorry to hear that. Yeah. It seems like a very inequitable thing as well, particularly given, some of the lack of choice.
Yeah, I see their logic in the research that, yes, some women need this day 2, day 3. If I wasn't overstimulated, they would have just grown them out to day 5.
Yeah.
That was not their policy. Their policy is we will try to do a day 2, 3, or if you can get them to day 5, we'll do a day 5. It was only because I could not have a fresh transfer that rigid procedure came into place. We will freeze on day 1.
And have you both found that there's been, in your experience, sort of a lack of consistency in things like those policies across the different providers?
Well, yeah, my other providers, my other 2, it's day 5. You grow to day 5. You may have a freeze all if you get sick, but they all grow to day 5.
That's been my experience with both providers. They all grow to day 5
Yeah.
and possibly day 6 if they're a bit slow.
True.
I just wanted to ask a final question, if I can share, just around care coordination, because you both mentioned that consistently in your submissions. I'm wondering if you have any examples of where there was care coordination. It may be the case that there wasn't, and what made that different, what made that work. And if it is the case that there wasn't, you can't think of an example where there was, what is it that we can suggest or recommend to assist with that?
Do you have any?
The most recent pregnancy I've had, my provider, I had to escalate out of the public into a private provider to be able to PGT test remaining embryos because I had 2 miscarriages in a row. I had to have a hysteroscopy as well, and my public clinic couldn't do the hysteroscopy. My specialist there was a endocrinologist, not a surgeon. So had to transfer out to a private clinic to get that process done. And the provider there, after I did get pregnant, had, as I said, he communicated back to my GP all the problems I've had, as well as my risk factors, what medications he had me on, all that sort of stuff, and what he would somewhat recommend I continue with care with him. That has been a really different experience to all my other providers and my other specialists. That referral back to my rural clinician has been amazing. It's also meant that I was able to pick up a GP obstetrician here and work with him more closely. He has that history and he's able to follow exactly what he's supposed to do or what he's suggested to do, but also then take on care as he sees me progress or sees something else come up. I had a bleed in this pregnancy a couple of days ago and ended up in emergency again for that. Because I had all that documentation that was given to me, I was able to hand that over. So I know and my specialist didn't actually give me back to my rural clinic until after that almost first trimester was over. That's been a really different experience, and I think that has helped because I was able to then go through an emergency with all this content without having to repeat my story, and they were able to treat me and move on, and it just seemed things got done quicker and I wasn't having to advocate as strongly for myself or repeat myself or find my own resources because I was under the care of a local GP obstetrician. And he works really closely with the Armidale Hospital, so that was nice.
Yeah, thank you.
Sort of following on from that, and I know, Sophie, you talked about it in your opening statement as well, and you basically said that you've had to coordinate your own care, transfer medical records, be your own advocate. Can you talk to us a bit more about that? And then also, I guess, like if we were to recommend as a committee to put more resources in place for women like the both of you going through this, who would be best placed to help you with that sort of coordination? If you don't no, that's fine. But I'm just wondering, particularly because sometimes you have a public hospital journey or a private journey, there's great organisations that work in these spaces. Should they be funded to help? I mean, what would have made it better for you, I guess, is the ultimate question.
Well, with Monash, I'm given a nurse that does look after me, but because I don't get any of my testing done up there, it is okay, well, you go and get your bloods done, go and get your ultrasounds done.
Yeah.
And then it filters back through her. That's a big question. I don't actually know the answer to that.
Yeah. Which I guess probably shows why it's so complex that there isn't an obvious sort of,
Yeah, there's a lot of fighting and self-advocating, a lot. Because you ring a pathology place, for example, and they guarantee you're going to get the same day turnaround. So then you go and get your blood test and you don't get it. So then you're dealing with your fertility clinic. And then you're also dealing with your own schedules, your children. Like it's just you're fighting on every front. So I don't know what the solution would be. What do you think?
As a start, if everyone could just start putting into My Health all their records, that would be a big help.
Yeah.
Train staff.
None of my ultrasounds are in there and I've had to go through 4 providers. I have to gather all that information and sometimes you can't get it directly. They're like, I'm sorry, go to your GP and get that. Oh, that was 3 years ago, that surgery you had? Oh, let me find that in my records. And they're going through emails and that's what it's a nightmare. If it was just put in the appropriate place. I have signed all the documents. It's all there. You're allowed to do this.
Yeah.
Why is it not done?
Do you think also too, and this has come up on some of the other days, even and you mentioned before sort of having to tell and retell and even going through, your current pregnancy, understanding that there might be a bit more anxiety because of what you've been through, some way to almost make it clear, even if you do have to go to different providers what your journey has been to this point so that you're not retelling again and again why you're there. It sounds simple, but would something like that help as well?
Yeah, look, honestly, and I think there's even a section in My Health for something like that.
Yeah.
This is not necessarily, IVF treatment is not a medical condition. You might be doing it because you have a medical condition.
Yeah.
But perhaps that is something to be thought of in that space where all your providers can access, I don't really want to say your story, but some of these factors.
Yeah.
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 That's a really good idea.
Yeah.
But I think it's a some sort of care plan. Like if you had diabetes, for example, you've got a management structure in the My Health that you can use with preferred providers and everything as well, and they upload everything to do with that there. If you're dealing with a chronic condition, yes, I have chronic conditions, but my IVF is not the chronic condition. But it's part of the story.
Yeah.
And things that something that can talk across state lines as well.
Yeah.
Oh, yeah.
Because that's a really big one for us. Like pathologies there's no system for Queensland doctors to log in and look at any New South Wales results. So when my results are available, my New South Wales, like if I had a OB in New South Wales, she'd be able to just log in and get them. But because they're in Queensland, it's phone calls and sometimes faxes are sent with results. So there's no system that crosses the state line.
And you talked before too about obviously having been sort of quite public with your story and other sort of local families and women knowing what you've been through, sort of being the one that people come to for advice or support. And obviously we're hearing after the break for some amazing women working in great organisations who help people going through the fertility journey. But do you think that there's a gap in terms of that support that's available? And obviously the mental health support is part of it, but even just that general sense of community so people don't feel alone when they're going through
Absolutely. There's a huge gap.
Yeah. What would be better? More funding for organisations, more local supports? What would you like to see?
All of the above.
Yeah, okay.
Yeah. Because it's so isolating when you're going through it, and especially in rural communities when traditionally they're very good breeders in the bush, and when you're not, you feel quite isolated and like you're not a part of it. But I've noticed since talking about it, there are a lot more people going through what I'm going through, but they don't talk about it.
Yeah.
So I think funding would be a big one, so people don't feel alone.
Yeah. Just looking if anyone's got any other questions, Amanda, at this point. Greg, do you have anything? No? Em? No? Well, I'll ask another one if we've got a few more minutes. The endometriosis diagnosis that came a little way through your journey, can you tell if, again, only if you're comfortable, but I guess what difference it would have made if that was sort of picked up earlier?
I think I would have fallen pregnant earlier. At the end of the 6 transfers, I started really asking questions like, why is this not working? There is no reason that you can give me that it's not working. All my embryos were A grade. My husband's sperm was great quality. My endometrium lining was thick enough. Like I ticked all the boxes, but nothing was working. And his response was very invasive and very expensive testing. And none of them included a laparoscopy to just have a look at what was going on because nothing was showing up on his ultrasounds. So there was no reason to cut me open, for no reason that he could see. And it just didn't sit right with me. Just the testing he wanted to do was incredibly invasive, and I just really followed my gut and just had to say that's not my path. I'm really not feeling this, and got a second opinion. And within 10 minutes of my first appointment, she said, Sophie, I'll eat my hat if you don't have endometriosis. And my first transfers after my excision surgery, so within that surgery I had a D&C, so they cleaned everything out, flushed my tubes and did a poppy seed flush, which helps embryos stick. And I fell pregnant straight away on my next transfer, which were twins, but we did lose them. And then she decided not to use any of my old embryos, and we did a fresh collection and fresh transfer, and that's when we got Tommy. So, yeah, it impacted hugely on our success rate. And my specialist says the reason it didn't work was because I was full of endometriosis.
Yeah, right. But for a long time, you didn't even know.
I didn't know.
Yeah.
And it wasn't on his radar, which is incredibly alarming.
I think Susan's got a follow.
As a follow-up to that, we heard evidence in the previous hearing suggesting that if there are fertility issues, especially because it's sort of an IVF-centred process in some ways, the first response is IVF rather than could you have endometriosis? Are there other issues? Are there other ways of approaching this rather than going straight to IVF? Would you have any comments? Do you think that's been true of your experience, that we've got too narrow a focus on if...
I think in some cases, yeah. I also have PCOS and it doesn't make, and one ovary, so my journey is not going to be easy regardless. But I think endometriosis is just starting to stick its head up awareness-wise, and I think in time it will be looked at more closely over IVF, I do believe,
But
as a first option.
I mean, with respect, you'd expect a fertility specialist to be aware of endometriosis.
You would. And alarmingly, I'm not the only, well, a friend of mine has just gone through that same clinic and she's had 12 failed transfers. And she then went to my specialist and she found stage 4 endo as well. So it is alarming. Because there are clinics out there who do the cookie cutter approach, but from my experience, if you do not fit that cookie cutter mould, it doesn't work because they're not expanding on that. So that's been my experience.
So you would support a broader look at reasons for infertility?
Absolutely. And that does start at a GP level because you have to go there first to then get your referrals.
Jumping on that, I think one of the criticisms we've heard from other witnesses to the inquiry is that IVF is so overwhelmingly provided in the private sector that there's actually a profit incentive for IVF clinics to provide IVF because that's what they do.
It's a business, yeah.
And not necessarily provide comprehensive gynecology care. If there were an option for a public clinic, the New South Wales government funds 3 public clinics at the moment in Sydney. If there were a public clinic in New England somewhere, would it be your preference to access that?
Oh, absolutely. Anything to save, 13 hours in the car just for a transfer. Absolutely.
Could I just ask you, Kira, because you're using the public clinic in Westmead, is that right?
Yep, we still have embryos there. Yes.
Yeah. Have you noticed, do they take a more holistic approach to fertility issues or do they have the same IVF only focus?
You have to pick your specialist first. I think they would all have different opinions. I did come with a complete diagnosis by the time I got to them. It wasn't until 6 transfers in with them that they sort of realised something else on top of that was going on. And that's when I had to go for another surgery, a different kind of surgery for the hysteroscopy. I wouldn't say that my particular specialist at that clinic was very much go straight to IVF. And also when I was in Port Macquarie, I did IUI first. He did a laparoscopy with endo excision. That was an accidental find as well. I didn't fit the standard endometriosis symptoms. I do now. It's funny how you have the surgery and sometimes it can set off some of those pain things that might be traditionally found. So I went in for that original surgery with a cyst that was on my ovary, turned out to be nothing, and that's ended up being a 4-hour surgery or something like that because of the endometriosis. But he was adamant that I didn't need IVF at that point. They'd found the problem. That's why. Then we tried IUI. Unfortunately, it didn't work, and we had to go to IVF. And it turns out, many years down the track, my egg quality is probably poorer. And now that we've done PGTA, we can actually see that it's a maternal gene problem in most parts. Not that I have a genetic condition and I'm not passing a genetic condition on, but it's a potential that the endometriosis attacks the eggs that are growing or has an inflammatory response to them and is producing mismatches in where the chromosomes are or missing chromosomes on the maternal side. So that's a much bigger picture now. No one recommended PGT up front. They didn't have any reason to it. So I guess my experience, I haven't necessarily been sold something I wasn't trying for. And if I could go back, I would do IVF from day dot. But that's hindsight for you.
No, thank you.
I think that brings us to the end of our time with you both today. But I just want to say once again, thank you so much for being here and for sharing so openly with us. I don't think you took anything on notice, but we might have some follow-up questions after today that the committee wants to put to you. So if that's the case, then the Secretariat will be in touch. But for now, thank you, and best of luck to both of you with your pregnancies. We're very much backing you, so hopefully you've got a great outcome by the end. So thank you.
Thank you.
And we'll now have a break for an hour and we'll be back at 12:45. So take your time. There's tea and coffee. So thank you for being here.
Thank you very much.
Great. Thank you. Well, welcome to our next panel of witnesses, and thank you so much for making the time to be here today. Just starting, could I ask each of you to state your name, your position title, and swear either an oath or an affirmation? And we'll start with you, Mrs. Laurie.
Hi, I'm Mrs. Jen Laurie, and you spell my name Jenlaurie, and I'm the founder and director of Her Herd Australia. I'm also a perinatal and paediatric mental health clinician here in the New England. And I'm swearing an oath. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Hi, my name is Claire Brett, and I'm the Regional Rural Ambassador for Pink Elephant Support Network. I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
I'm Helen Payne, the CEO of the Tory Fernand Foundation. I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Hi, I'm Sally Rawlings. I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Hi, I'm Kylie Birkinshaw. I am on the State Social Issues Committee for the Country Women's Association, New South Wales. I swear that the evidence given now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you.
Paige Shanna Briley, CWA Virtual Branch. I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth and the whole truth and nothing but the truth.
Excellent. Thank you so much. So there is an opportunity for each of you or your organisations to make a brief opening statement. We do have a bit of time with this panel, which is good. So feel free to take your time when you give us your opening statement. But again, we might start with you, please, Miss Laurie.
I've gone the technology route and I've got it on my iPhone.
Love that.
So sorry.
That's fine.
So my name is Jen Laurie. I'm a perinatal and paediatric mental health clinician, rural social worker, and PhD candidate with the University of New England. I'm also the founder and director of Her Herd, a rural social enterprise dedicated to amplifying the voices of women and families navigating fertility, pregnancy, and early parenting in regional, rural, and remote Australia. Her Herd was not built in a boardroom. It's certainly a grassroots organisation if anyone's met me. It was built through conversations with women sitting at kitchen tables, in community halls, and in the moments of crisis. What began as storytelling has grown into a national advocacy platform informed by both lived experience and clinical and academic evidence. Through our podcast, national survey work, and ongoing engagement with communities, clinicians and policymakers, we have collected hundreds of stories. While each story is deeply personal, the patterns are strikingly consistent. What we are seeing is not isolated hardship, it's system failure. Women are travelling hours, sometimes days, for basic tests and appointments. Care is fragmented with no one clinician or services holding the full picture. Diagnosis, particularly for conditions like endometriosis, are delayed or missed altogether. Men are often excluded from early interventions or investigations, placing an unnecessary burden on women. And across every stage, miscarriage, fertility treatment, pregnancy, and postpartum mental health support is either absent or left for individuals to source themselves. What compounds this cost further is rural families are not just paying for the care, they are paying in travel, time away from work, separation from children, and a cumulative emotional strain. As one woman told us, she drove the equivalent distance to Perth from New South Wales for blood tests during one single cycle. Another missed her child's first words while undergoing treatment away from home. These are not exceptions, they are predictable outcomes of a system that has not been designed with rural families in mind. At the same time, what we want to acknowledge is the incredible rural midwives, doctors and nurses who embed themselves in our communities. They are often sacrificing holidays, cancelling trips and working endless overtime. They are the backbone of rural maternity, fertility care and carrying communities through gaps in systems and policies that make no sense. Their dedication is rarely recognised, yet without them, rural families would have even fewer options. What is clear from both the lived experience and evidence is that distance, lack of continuity, gender assumptions and compounding costs are the barriers. They are the detriments of outcomes. Her herd's position is that rural women and families should not have to carry the burden of navigating this system alone. Rural families deserve more than making do. They deserve systems built with justice, empathy and equity so they are no longer required to travel extensively, have fragmented care or carry the financial and emotional burden of accessing something that is a fundamental right. To the families who continue to fight for the chance to grow and thrive in the bush, we say thank you. Your stories are the reason we are here today. We like to thank also the committee for this time, their diligence and the willingness to hear and hold the stories for rural families. On behalf of her herd and the communities we represent, thank you for this opportunity to contribute.
Thank you.
Good afternoon, Chair and committee members. My name is Claire Brett, and not only do I live in regional New South Wales, but I'm also the Regional and Rural Ambassador for Pink Elephant Support Network. I have lived the exhausting reality of recurrent pregnancy loss, experiencing 5 miscarriages. 6 months after my first loss, I was in a mental health crisis, seeking help for anxiety entirely on my own. I was discharged from hospital after my first D&C and as medically stable, but I was emotionally shattered, without a single referral or support number to call if or when I needed it. My story began in 2020, but the system is still failing regional women. Recently, a woman in my community shared with me that she has undergone 3 D&C since February this year. While in her hospital bed, an anaesthetist joked that he would probably see her again. Between the rotating door of locum doctors and conflicting advice, she has received 0 specialist referrals, 0 mental health support, and she did receive the text message from New South Wales Health that she would receive a follow-up phone call, but months later, that still hasn't come. In her most vulnerable moments, the system put the entire burden of advocacy back onto her. In a regional town where GP appointments have a 3-week wait, she has been left with nowhere to go. She is parenting, she is grieving, and she is fighting a system that should be fighting for her. This is the postcode lottery in action. While a town like Tamworth has an early pregnancy assessment service, many across New South Wales don't. A woman's access to a quiet, specialised, trauma-informed care shouldn't depend on which road she has to drive. Because most regional and rural hospitals lack this service, many of us are forced into the chaos of an emergency department, triage along general trauma cases, people we know, while actively losing our babies. This inconsistency is unacceptable. Why is the dignity of our care determined by where we live? And why are regional women treated as a lower priority? We need to stop treating miscarriage as a minor clinical event. It is a major women's health issue. I'm calling for mandatory early pregnancy assessment services in every public hospital, including regional hubs. Specialised pregnancy after loss pathways. We need a rainbow-style clinic care models in all New South Wales hospitals to provide that continuity of care. We need automatic follow-up support. When I birthed my living children, I couldn't leave the hospital without being assessed and paperwork given to me. Why is the level of care so different when I don't leave with my baby? We must mandate that no woman leaves a hospital in New South Wales after a pregnancy loss without a clear mental health pathway and physical resources in her hand. Charities like Pink Elephant Support Network. We need mandatory trauma-informed training for pregnancy loss. The sensitivity of a healthcare professional must be at a clinical standard. At Pink Elephants, our core values are validation, empathy, and connection. These shouldn't just be the values of a charity. They need to be the minimum standard of care across every hospital in this state. If we want mothers to continue showing up for their families, workplaces, and society, we must stop expecting them to carry this grief alone. Right now, the right care you will receive is determined by a postcode. Regional families feel invisible. I felt invisible. And I see it in my community still today. We all deserve to walk into any hospital across New South Wales and receive the same care, not just for our bodies, but for our hearts, no matter where we decide to call home in New South Wales. Thank you for your time and the honour of being here today.
Thanks, Claire.
Thank you for the opportunity to appear today. I'm speaking on behalf of the Tory Fernane Foundation, a regional New South Wales charity dedicated to improving maternity, neonatal and women's health outcomes, particularly in rural and regional communities. Our work focuses on strengthening systems that support families through fertility, pregnancy, birth and early parenting, with a particular focus on equitable access to services regardless of postcode. TFF operates across 4 strategic pillars: investing in critical maternity and neonatal care infrastructure, uplifting regional midwifery and nursing through professional development, investing in research to identify the most impactful improvements in regional care, and purchasing equipment for maternity units and special care nurseries. A key message of our submission is that regional midwives and nurses are often the first point of contact for people experiencing fertility issues or pregnancy loss. We believe that there's significant opportunity for government to strengthen regional workforce capability through targeted fertility education, coordinated regional care pathways, telehealth-enabled shared care, and enhanced psychosocial support for pregnancy loss. If we invest in the regional workforce already caring for families, we can reduce delays, ease travel burdens, improve continuity of care, and ensure postcode is less determinant on fertility outcomes in New South Wales. So we welcome the opportunity to contribute to this important work.
Thank you. Did you want to add anything, Mrs. Rawlings, or just wait for questions? It's up to you. You're welcome to make a statement.
I just thought I'd
Yeah,
introduce
please.
myself.
Yeah, yeah.
As a nurse and midwife, I've had the privilege of working in hospitals and maternity services, both metropolitan, regional and rural areas in New South Wales, where I have witnessed the challenges that families face with fertility, pregnancy, birth and perinatal loss. I recently connected with the Tory Fernane Foundation and support their work, which focuses on strengthening the systems, as Helen just said. I now reside in a regional area of New South Wales where I care for my own ageing parent, but I often find myself assisting family, friends and friends of friends to navigate the complexities of fertility, pregnancy and birth care. I'm here to support in support of the Foundation's recommendations of strengthening the workforce capacity, integrating telehealth and supporting continuity of care pathways to improve outcomes for regional families. Thank you.
Thank you. Birkinshaw?
Good afternoon, Madam Chair, members of the committee. My name's Kylie Birkinshaw and I'm here today representing the Country Women's Association, New South Wales, State Social Issues Committee. I also belong to the Terrigal Evening branch on the Central Coast. However, I grew up and went to school here in Tamworth. So this issue is deeply personal to me, not only as an advocate, but as someone who has lived it. From my early teens, I experienced severe recurring pain. As a young woman, I constantly visiting my GP to understand what was happening to my body, but time and time again, my symptoms were dismissed or minimised. It wasn't until I was 30 years old, after being admitted to hospital with suspected appendicitis, I finally received the answers. During surgery to remove my appendix, doctors discovered I had stage 4 endometriosis and potentially adenomyosis. That moment should have brought relief. Instead, it marked the beginning of such a harder journey. Shortly after, I was told by fertility specialists that I should have already been thinking about starting a family. Like many women, this was something that I had always dreamed of. But what followed were 5 years of miscarriages, failed attempts, and ultimately breakdown of my relationship under the weight of it all. I felt lost, I felt defeated, and at times I felt broken. What I didn't know then, but know now, is that things could have been different. If I had been given the right information in my 20s, my symptoms had been taken seriously earlier, or if I had an empathetic or informed team of GP and specialists, my pathway may have looked very different. I may have been given the opportunity to understand my condition sooner. I may have been able to have considered options such as fertility preservation, including egg freezing, at a time when it could have made a difference. But like many women, in particular those in regional, rural and remote areas, I didn't have access to the information or services when I needed them most. This is why equitable access to pelvic clinics, specialist services is so important, especially in regional, rural and remote areas of New South Wales. Women in regional, rural and remote communities deserve the same access to early diagnosis, education and treatment as those in the metropolitan areas. They deserve to be believed, they deserve timely care, and they deserve choices, because this is not just about managing pain, it's about protecting futures and preserving fertility and ensuring that no woman is left wondering, what if? Thank you for the opportunity of sharing my story.
Thank you. Did you want to add anything? Right, yep.
Good afternoon, Chair and members of the committee, and thank you for allowing me to speak today. My name is Paige Briley, and my IVF journey started when I was 22 years old. At that age, I had no idea what I was walking into. All I knew was that I had severe endometriosis, and I was told that IVF was our only option if we ever wanted the chance to have a family. Like many people, you put your trust in the doctors and think, we just need to try. But after my first IVF round was unsuccessful, I quickly realised how emotionally devastating this journey could be, and the hardest part was finding the strength to walk back through those doors and try again. Over the past 8 years, I've gone through multiple IVF rounds, with each cycle costing up to $20,000. The financial pressure alone is overwhelming, but the mental and emotional toll is something that is very hard to explain unless you have lived it yourself. What I found most difficult was the lack of genuine support throughout the process. At times, you feel less like a person and more like a number. After several unsuccessful rounds and nothing really changed in my treatment, yet you continue to hold onto hope because the hope is all you have. As my journey continued, we discovered I also had adenomyosis alongside severe endometriosis, meaning I needed more specialised care. We had no choice but to travel over 7 hours to Sydney for treatment. Each trip meant staying away from home for up to 2 weeks at a time, away from our family, our animals, our support network, and the comfort you desperately need during such a difficult period in your life. Regional Australians should not have to leave their homes, their support system, and their financial exhaustion themselves just to have access to proper fertility care. I'm sharing my story today because fertility treatment is not only a medical issue, it is an emotional, financial, and deeply personal. There needs to be more support, better access to specialised care, and greater understanding of the long-term impacts this journey has on individuals and families. Thank you.
Thank you. Thank you all, and again, on behalf of all the committee, I'm sure, just for sharing particularly the personal stories. It's very powerful for us to hear that, and it's not an easy thing to talk about. So we certainly are really appreciative that you're able to do that. And I also just wanted to note through the Her Heard submission. I know there are a lot of lived experience stories told through that, and we're very grateful to those women and families for being able to share those with you, Jen, to then pass on to us. So thank you. We will, some of you have been here earlier, but we'll just do sort of free flow questions. We do have one of our community members online as well who may have some questions. But like I said, we have plenty of time, so we should be able to get through what we want to talk to you about. I might ask a couple and then I'll sort of hand to whoever else. We'll do a bit of back and forth. But there's obviously a lot and a lot of a range of issues that we're looking at as part of this committee. But I wanted to start with a few of you have mentioned the diagnosis of endometriosis coming and what that has meant for your journeys, and probably tying a bit back into Tori Finane as well. In terms of sort of the clinical expertise that we need in regional communities, being able to pick up some of these issues earlier and the difference that might make for women and families, where do you see some of the gaps in terms of that particular part of the health service in your experiences? And I'm happy for whoever wants to answer.
From my perspective, it was having to travel to Sydney just not to see a gynecological doctor, but to see a specialised gynecological doctor that specialises in endometriosis, to be able to advise me of that direction, because I'd had gynecological services here in Tamworth. However, they weren't specialised enough in order to go to that next step of being able to start a family.
Consistently in all the heard stories, it's never a first thought, and some women are quite often shocked when they are presented with that. But I was just doing a quick count in my head of all of the stories we've told, and I don't think anybody came to IVF with endometriosis. I think most of them were found as a subsequent of IVF being unsuccessful. I think the other thing to have a consideration around is a temperature check around endometriosis and intervention at the moment, given some of the stories that are in the media as well at the moment. Women are going to be fearful around treatment plans, particularly invasive ones.
And it sort of leads, I guess, from that. But I guess the education piece, and that's something that the CWA submission touches on as well. But we've heard evidence from other witnesses throughout the inquiry around sort of what is and isn't taught in schools, for instance, about fertility and what that journey looks like. I think we had someone say when we were in Sydney a couple of weeks ago that you get taught a lot about what to do to not get pregnant, which is important, but also that other piece around what fertility looks like, male infertility as well being a big part. And I know heard you call out that in your submission as well. And I think Pink Elephants you do as well. So what would be some of the recommendations that the committee you think could make around sort of the education piece early on for young people, for men, so that there's more awareness about some of these issues and challenges and better information in the community?
Well, a quick review of the PDHP curriculum for sex education in those really key years would be a really quick way to whip a dot point into that kind of curriculum and say, hey, we talk to them about this stuff. What that looks like for each individual school will be different, but at least it'll be their part of the curriculum is a really quick and safe way to be able to do that. I think Soph touched on this earlier. In rural communities, their bread and butter is breeding cattle and sheep. So having fertility conversations in the context of those communities is much more difficult. And we've found at the Herd the biggest success is through peer moderated situations with that, particularly around miscarriage.
Did anyone else have a view on that space? Yeah.
Also the tyranny of distance. Kylie has spoken about the need to travel for expert care or specialised services. I think that the importance of having other ways to access these services, whether it's on the virtual platform or through local training for diagnosis at the local level. Is important.
With my experience, I first had a miscarriage and I was 30 when I had that. And my experience of a miscarriage is what you'd see on the movies, where you would know that you were having one. And I always thought, I wish I had that educational knowledge. And I also felt a bit embarrassed being a female that I didn't know there were even differences in what type of miscarriage there are. I also had a chemical pregnancy. So again, until I had that type of loss, I wasn't aware that there were different types of losses. So I think that education, starting young in school, would be a really good thing, just to have a broad idea about what type of miscarriages there are, and also what that even looks like.
Certainly, I think men need to be more part of the conversation with fertility treatment. That's certainly been my own personal experience. My husband has a submission inside our submission, and has appeared on the podcast. In our first round of fertility treatment, in order to achieve Charlie, I was 7 months into treatment and torture of medication and drugs, and it turns out I wasn't the infertile party, my husband was. And it was a nutritionalist who was watching me essentially suffer psychosis from drug induction medication say, has anyone tested your husband? I'm currently undergoing fertility treatments again, and my husband is under the Medicare rebate. He didn't attend the doctor's visit. I double booked the appointment, but he didn't go. And at my last fertility appointment, they were like, oh, no, Chris's diabetes is good. We won't worry about him. So he hasn't been to any of the appointments. And I have a lot of health literacy. So I think often they're very easily excluded from the conversations.
And I'll just have a couple more and then I'll hand over to some of my colleagues. But your in your opening statement, Claire, and you talked about, I guess, the experience of, when you go through loss and you leave the hospital without sort of any supports. And, obviously it's very traumatic to hear that happened to you. And I know that you're not alone, and others have lived experience with that as well. What are some of the things from, I guess, your personal experience, but also the work that you do with Pink Elephants, and particularly with that rural and regional lens, that you think we could recommend to have in place in some of our regional hospitals to offer better support for women who do leave after having experienced loss?
Yeah. I think before I leave the hospital system that there's a checklist that I've been seen to by the social workers at the hospital if they're available. And just a simple hello, where I'm a social worker, you might not need my help now, but you might later down the track. And in my case, I probably wouldn't have taken that help at the time because I just wanted to go home.
Yeah.
But 6 months later, I definitely then did need that help. But I had to actively seek that help myself while actively grieving multiple miscarriages, along with also parenting my eldest son. So I think before I leave the hospital, just like the case is when I do have a child, that I'm given physical paperwork, like charities like Pink Elephants, but there are a lot more other charities as well. And local, if we can localise it too, that would be amazing as well. But I think having those physical resources and phone numbers and people to call, online services and forums would be great, because the self-active, work that you have to do while you're grieving is a lot of people don't end up getting that help because it's too hard while you're in the middle of it.
Yeah, and I think some of the other, I think it was the Gidget Foundation, when they appeared, talked about grief not being linear. And as you said, you might not want something straight away, but in a few months or even further down the track, it might be something that you need to be able to access.
Yeah.
And do you think that sort of should also be available sort of more broadly to women and families going through a fertility journey, whether they've experienced loss or not, just knowing who to talk to? And that's probably open to the whole panel for comment. But yeah.
Even in our GP, GPs and schools and workplaces, it should be available to every woman in those sectors, because you might go to your HR department and say, I've had a miscarriage, and that they should have those resources available to them too.
Did anyone else have?
Absolutely. I think it's imperative that it's across the board, especially with fertility journeys, that everyone has access to that or knows where to find it when they do need it. You might not need it today, You might need it in 6 months, you might need it in 12 months, but knowing where to find available access to assistance is imperative.
Yeah. Did you want to add something, Ms. Pryor?
Yeah. With my journey, I was really young, starting to go, and I turned up to the doctors, and it's very overwhelming being very young, but at any age it is. But having severe endometriosis, so I just had my 16th endometriosis operation. I'm 10 weeks post-op. And even just having the support for both sides and being able to go to your GP and they actually understand and have kind of ways to support you instead of being like, just go and see a gyno. But you don't just need a gyno, you need a whole team that's going to support you through this time. I'm 8 years in to mine and multiple rounds of IVF. And pretty much the one thing that I can probably say is when the nurse rings you to tell you it's unsuccessful, most of the time I've got told, just give us a call when you're ready to do another round.
Yeah.
Like there's no, and yes, they sometimes go, oh, there's counselling available, but it's more just like, well, when do you want to try again? They go on that hope and it's great, but how are you going to, where's the other support that's behind just going and jumping into another round? Your body takes a toll. It's all aspects.
Yeah, thank you for sharing. Go to Dr. Conn. Yep.
For our work. My first question is around navigating the system. I think obviously we will make some recommendations about improving the system, but improving navigation strikes me as very low-hanging fruit. And I'm struck by how many people we've heard from who are very brave, very articulate people with very high literacy levels who've talked about how hard it's been to navigate what's available and advocate for themselves. So I'm interested in what you would recommend in terms of how we can make that process easier for people, or what specific support they need to actually know about and get into the services that are available.
Look, regional, rural, remote health in general is a different beast, whether we colour that with maternity services or fertility services or miscarriage services. And so the herd is really strongly advocating for a centralised source of rural, regional, remote information. We would like to be that place. We're trying to build that, but finding funds is the biggest barrier to us being able to deliver it. We have a 5-year plan in seeing us deliver specific centralised information and peer support and clinical services, but that requires significant investiture for that to happen. And so I can bust my humps as hard as I want, but at the end of the day, they still need funds to be able to do that. And so I would say one of the biggest barriers for regional people is nothing ever colours it specifically for that. We were talking before about they might think they only have to travel for egg collections or egg retrievals or transfers, but then they find out about pathology services or the fact that the places had bad experiences with the sonographer in their local area, and so they don't want them to use that. And that just adds these layers of pressure, which then is associated with finances, and they're balancing, well, I have to spend a bit more, but I'll get a better outcome and I want to give myself the best shot. And they are weighing the scales that just no one should ever have to.
I suffered a lot through pregnancy after loss. So after my 5th miscarriage, I fell pregnant with my son Jimmy, but I was that was classed as a high risk pregnancy. So I was seeing a specialist. But when I did then go to see the midwives at Armada Hospital, the continuity of care that just wasn't there, which looks like it's discussed throughout the whole day. But after what happened to me and research through also with working with pink elephants. In the UK, they have a rainbow clinic in their hospitals where women who have experienced one miscarriage get different specialised care once they enter the hospital system again, if they're successfully pregnant again. And that just means you turn up and they already know why you're in there. You don't need to explain your story again. You're seeing the one midwife. You can go in and have multiple scans, reassurance scans, and doing so then doesn't put that burden of feeling like at the moment, if I was to go in there regularly, I would probably feel like I'm a burden on the health system for doing that. So I would love to see some sort of care for women who have experienced losses across the board, that when they do enter the hospital system, there is a different type of care given to them, that they already know walking in there that they're here because they've had a loss.
Got more questions, but feel free to add to that before we move on.
Oh, okay. I think that as a midwife, I have a great understanding of the benefits of continuity of care and carer, and it's very well evidence-based that outcomes are improved with that continuity. I think an investment is needed into the fertility space. That we've now invested into pregnancy and birth and aftercare, but that investment into the fertility space is really what's needed, because continuity of care and carer will make a huge difference.
I think this committee owes in good faith to have a look at EPAS clinics and their funding and how that looks like in rural and regional and remote Australia. I think, EPAS clinics were a fantastic thing that came out of a New South Wales inquiry many moons ago. And I think that the community really needs to have a look at their distribution, their funding and their operation and policies, if I can be so blunt.
Agreed.
Can I come back to the Tory Finane Foundation? You wrote in your written submission about some workforce issues as a barrier to equitable care in the regions, which is something we haven't really explored in detail yet. Could you speak to those issues and what needs to be addressed?
Absolutely. I mean, the Tory Finane Foundation was founded after the death of Tory Finane, who was a midwife in Orange, and her family wanted to start initially with supporting midwives through very small professional development scholarship pieces, and we have grown to support many more projects, but we rely, in terms of where we invest the funding that we raise is based heavily around the advice we get from local health districts. And we put this submission together based on so many conversations with Sally as an example, but many, many other midwives and particularly special care nursery nurses around a number of different local regional health districts. So Murrumbidgee, Southern New South Wales, Far West New South Wales, Western New South Wales and Hunter, New England. And we've also spoken to many mothers and families to really identify what those 4 key areas are that I mentioned in my opening statement and in this submission. I think and workforce shortages has come up in almost all our conversations, but also the burnout that midwives and nurses are stretched beyond their capacity. And that was a key point that I was well aware of, not adding more work to these midwives by submitting our opinion, but really passing on the information we have received and through many conversations and years now, is that regional patients, coming back to your original point, frequently navigate the fragmented care pathways, and a dedicated fertility midwife or nurse could coordinate and facilitate all the different aspects of that fertility care, but also because midwives have, and Sally can talk more to this as well, already have that knowledge of perinatal, postnatal, labour, birth, etc. So that continuity of care is would be much easier to facilitate if that initial coordination could happen more easily.
Yeah, sure. It's not necessarily about nurses and midwives being everything to everyone. It's about having that point of contact for each and every woman, which I think is so important, that for then providing care, definitely, but for ongoing referral and consultation.
Thank you. Can I ask one more?
Yeah,
Jen,
of course.
from you? Coming back to heard, you made a very interesting point in your written submission about the impact of quiet withdrawal and cancellation of abortion services in many rural and regional areas and the flow-on impact that that's had on miscarriage care. Could you explain that point?
Yeah, I think we've seen this fairly well documented in the media of just, I think I explained it as a quiet cancelling. It's like it's no longer available here. When you present for a termination in regional, rural, remote, or anywhere really, it's not designated whether it's a termination for medical reasons or it's a termination by choice. And so when you cancel those services because you no longer want to provide them for whatever reason that may be, and I'm not getting into that today, you essentially remove healthcare for women. And that is healthcare, essential healthcare, full stop. There is no debating about that. And so women are now travelling further and further. And also it creates a stigma around those discussions about that. I have friends who will openly talk about their stillbirth, but they cannot talk about their termination for medical reasons. And I think we have no idea of the significance around the trauma and the impact that that has on the individual because they're just not coming forward to report the data.
Thanks, Chair.
Yep.
Just to follow up on that, when you're talking about and conscious of what everybody has said today and in other hearings about the total lack of psychological support, and I think what I'm hearing today and on other days, the total lack of recognition of the loss and the grief surrounding a miscarriage. Are we also underestimating loss and grief through termination, even elective termination, as if problem solved, off you go? I'm not equating it to miscarriage, but miscarriage, oh well, you've had the miscarriage, off you go. Are we encouraging women to provide full medical histories and recognising all of the loss and all of the grief that they may have suffered along what could be a very long fertility journey?
I've had a termination for medical reasons for my first, I call it a miscarriage because it's easy to talk about in conversation.
Yeah.
But my first loss was a termination for medical reasons. And when you present at a hospital when you're about to have a live baby or a Caesar, as I do, they count. So they'll say you've had 5 pregnancies and 2 live births. So they don't delineate whether or not it's a termination for medical reasons or a miscarriage, in my experience. I certainly know that I didn't get any follow-up care. I went privately, and I don't know if the woman sitting next to me was an abortion or a termination for medical reason. We all got the same treatment. And
in terms of follow-up care or even a recognition that 6 months later you might need some follow-up care?
Absolutely none. I had the worst perinatal anxiety with my firstborn son. I hadn't cut any of the tags off his onesies until I was 38 weeks.
Sorry. No, I'm sorry.
Yeah.
Anybody else have a comment or perhaps, Ms. Payne, if I could just come to you. Regional and rural workforce issues really clear. I guess what I'm trying to get a sense of, is it a question of upskilling the existing workforce, or is there a question of just sufficiency of existing workforce?
I think it's two-pronged. I think initially it would be the sufficiency of the current workforce. I think we need more midwives, and that was as I mentioned before, don't want to overburden or provide more work for these overworked midwives and nurses. So I think that's the biggest piece, is growing that workforce and ensuring you have we have the right skilled workforce as well. I think the work that midwives and nurses do in regional communities is very different to metro nurses and midwives, as Sally, again, has been a great advisor to us in that regard. I think, coming back to your original question too, that Jen just answered, it is looking at who the right partners are when it comes to who can influence, I think, projects more quickly. We have found that that we have had the capability to influence projects obviously more quickly because there aren't as many barriers to us investing in key projects that will make a difference sooner and make a bigger impact. And one example is expanding the special care nursery in Orange. So we've doubled the capacity. We have contributed the most significant amount to doubling the capacity of the special care nursery, which so from 4 beds to 8 beds. And I think it's now we're also having the conversation of how we can support that workforce.
Yes.
Now that there's that expansion.
Yes.
So it's connected to many different options. If you want to offer more, I think we need more skilled people to do it.
I recognise that this is the question that wins you a house on the Gold Coast and $5 billion in gold bullion if you can answer it. But are there barriers to growing a regional health workforce that we can remove? Should there be more retraining opportunities for women as a second career, perhaps in midwifery, who may have done something else? Are there things that you can see that we could be doing that aren't happening at the moment to upskill and encourage a bigger pool of health workers, especially in this area?
Look, I think that we're all aware that nurses and midwives are leaving the profession at a higher rate than has ever been known. Our replacement with younger, new, experienced midwives and nurses is a work in progress. And I think bringing those trainings to regional and rural areas is really important. There are women and men across New South Wales who don't want to leave their families to train. So there are training opportunities for regional and rural centres, and I think the Tamworth Hub is a great example of that, where people can remain within their community and complete their training. So I think that is important. The ongoing professional development of nurses and midwives in the rural sector is paramount. It's not about asking them to do more, it's about enhancing the care that they give by giving them the opportunity to attend professional development that's available to nurses and midwives in metropolitan areas. So bringing the education to the rural community is absolutely paramount.
Is it? Oh, sorry.
I was really lucky. I had a mum that dragged me to every doctor. I was very, very early getting my cycle. So from 10 years old, my pain started. So before I even went through IVF, my pain was there. And my mum took me to my GP. It was a country practice. I grew up in a very small town, and they don't have the knowledge of, they look at, and I think before you even hit IVF, it's going back to looking at girls and saying, oh, it's in your head, or things you don't want to be at school. But if we could actually go to our GP and they go, do you know what? Maybe you might have endometriosis. So then you can actually plan, because at 20 years old, I lost my ovary. So, and no one from my first surgery at 16 to 20 even said to me, hey, do you think maybe you should freeze eggs? So being able to talk to your GP, and most of the time they're your family doctor that you've been going to for years. They know your family very well. You normally can talk to them, but they don't have, I don't know, the resources, or they just kind of dismiss that girls can have endo at early ages. And I think that's where it actually starts before we get to that IVF and miscarriages and all those things. We can actually, yes, it's great to put into schools, but actually talking, our GPs where we're meant to go to start, or have a problem or have pain or bad periods. But as women, we're just getting dismissed. And that's where I feel.
I'm aware that there's a model in psychiatry where GPs, doctors have access to a phone number where they can call and get advice. Would there be any benefit if there was a similar sort of 1-800 obstetrician or something like that to get advice, do you think? Or is it lack of knowledge from GPs? Is it lack of awareness? Is it...
I think our GPs are jacks of all trades, and we don't have enough of them in the same way we don't have enough midwives or doctors, or nurses, or anything that's going on. So I think it's, how do you know everything about everything?
No, you can't,
But we coming back to what we have been asked to support is trying to get the education out to as many regional areas as possible. So we have invested in those travelling training pieces where midwives and nurses don't have to leave where they live. They don't have to find someone to cover their shift. It's much easier to get that education, and we have found a majority of our investment has gone to that. So not just fertility pieces, but fertility support, but a lot of the neonatal resuscitation aspects and finding the right trainer, or they've all been private providers, and we have paid for them to travel.
One last question from me. It's a bit of a left field question, but I'm interested in the discussion about, especially with endometriosis, it's perhaps not enough to see a gynecologist, you need a specialist. Are there issues developing in the regions? So we hear stories that because flights are being cut back or cut off to certain areas, that means that medical specialists who might have come and done a clinic once a month or something won't be coming to towns anymore. Is that emerging as an issue, and does that create a greater barrier for access to particular types of specialties?
To everything, even training and going down to getting your fertility treatment. So as a perinatal mental health clinician, I have to cancel a whole day of clients. That's 7 or 8 clients that I can't see then for that month. Then I travel down, and if my Qantas flight is cancelled for my own treatment, then I've cancelled the whole entire day, plus lost my flight. Then I have to rebook it and try and reorganise it, and it's just honestly a nightmare. The connectivity for us to get to there is, if you want to guarantee, you have to get in the car.
I think too, the establishment of endometriosis and pelvic pain clinics in regional areas could be an asset that then links in other specialised areas. But having 9 out of the 11 are in the Sydney metro area. We need them to come further past the Great Dividing Range.
And let's be frank, some women are waiting for a morphology scan up to 6 weeks and then finding out they still can't get in, so they drive to Newcastle. So, saying that we can then do the scans of, these are already overrun systems. Systematically, they're really broken. I don't think that you can underestimate what TFF are doing in regional areas at the moment. Putting an extra NICU bed in, that changes the game for so many people who have just simply got twins.
Yeah.
Like, you cannot underestimate what they're doing. I know of midwives out in non-birthing areas, that's a lovely government term, that just simply want to become nurse practitioners but can't get the funding approved for them to become nurse practitioners, so their clients don't have to travel 4 hours to get pathology slips. What TFF are doing is incredible. It is making a real difference.
And when you say the funding to become nurse practitioners, what does that mean?
I can't speak to the specifics because I'm not
Sorry,
actually a
yeah,
midwife. I can
yeah.
just tell you what the midwives are telling me, that
Right,
they
yes.
apply, it's I think $2,000
Okay.
to be able to get trained to be a nurse practitioner. That's additional time in training. You might be able to speak better to actually the physicalities of it, Sally, but they can't get it approved by New South Wales Health.
Okay. All right. Thank you.
To the point where I was like, personally, I'll give you $2,000, go and do it.
Yeah. Yeah. Okay. Thank you.
I think Miss Hurst has a few questions online, so she'll be up on the screen for the panel.
Wonderful. Thank you, Chair. And thank you all for coming today, and thank you also for very vulnerably sharing your own personal experiences as well. It helps us to really understand the depth of the issues here. I just want to go back to something that Jen was talking about before. You gave a really good example of what is described in some of the submissions as those gender assumptions and the burden and responsibility around fertility being on women. And you gave that really personal experience of your own journey with your husband. I just wanted to get some thoughts around what really needs to change in the system on a practical level to really fix this. We heard from some fantastic men's organisations in the last hearing day about the fact that even the research is focused on women rather than men, and so women are having to do invasive procedures because the research isn't there. But it also sounds like on a really practical level that the health experts are quite comfortable if the male is in the appointment, even if it is a male fertility issue. So I just wanted to get some thoughts around some of those more practical things that we need to recommend in regards to how the health system changes in that aspect.
Maybe looking at how the Medicare rebate works with men actually being physically present in the room. In order to establish whether or not the man is a factor in fertility treatment, this was one of the major barriers, and my husband will probably kill me. But to give a semen analysis in the bush, we had to drive to Tamworth, which is an hour and a half, and then he had to do it in the public bathroom of the pathology unit, which is attached to the waiting room. He said it was the most undignified experience of his life. So he'll be so pleased that I've shared it here in this open forum today. But I think there's a lot of just really little things that can improve the dignity of rural people, and particularly take away the barrier for men to be able to do that. I think that would be that allows you to start the conversation, and that took us 10 weeks to be able to achieve that, just to tee it up, get him away from the farm, work him up to do it. And he was so embarrassed that he'd had blood tests ordered at the same time. And he said, I put that cup down, I did not make eye contact with anyone, and I was out of there. So I think it's a huge barrier.
And I can see why he hasn't wanted to come to any sort of follow-up appointments either after that experience. I'm assuming that, once you go through something as undignified as that, is using the words that you've used, it's kind of very difficult to then obviously convince him to come to other appointments. I have a question for Claire as well. I'm just looking at your submission where you said that one of the recommendations in the Pink Elephant submission was to establish a rural and regional equity framework with cultural integration, which you say would involve dedicated coordinators, 24/7 services, mobile units, travel subsidies to ensure location doesn't determine care quality. I think this sounds like a really fantastic recommendation. I just wondered if you could talk a little bit further about how you see that framework working in practice and how it will actually fill some of the gaps that we're hearing about today.
I'll probably have to take that on notice. I believe Sam, our CEO, would be best to have that. But I can talk from a personal experience, perhaps, around travel. Is that your question? Sorry?
I guess it was more about, this whole framework which was proposed, which had stuff
Okay.
about travel in there, but it was also
That's
about
okay. I'd say if I can take that on notice and have Sam answer that, if that's okay. Sorry.
That's fine.
Emma is
I
frozen.
think we've just Emma's just frozen. Wait, no,
Oh,
she's back.
can
There
you
you
hear
go.
me now?
You're back. Yep.
Great. Yeah, sorry. I think it froze on my end too. Yeah, that's fantastic.
Sorry, I'm just
Thank
not
you.
across fully
okay.
about that. Thank you.
No, of course, absolutely. And I also wanted to go back to something that Kylie said as well. In your opening statement, Kylie, you talked about access to information and services, and we've heard a lot about access to services and the barriers there, but I was really interested in that access to information.
Yep.
I know we talked a little bit earlier on about the lack of education for many people working in the health sector in the regional and rural areas in regards to being able to pass on that information. But are there other aspects as well where, there should be more information coming to families in regional and rural areas in regards to fertility that currently aren't in place?
Mine's more from a personal perspective. When I was going through everything, I was classed as geriatric. If I'd have found out that prior, before my diagnosis, that I could have frozen my eggs for later implantation, it would have probably saved me a lot of grief. But not having access or knowing that that was available 30, 40 years ago, it was different.
I'm just wondering if anyone else has had, experiences with access to information that should have been readily available as well.
I mean, my experience when I presented to hospital to have a DNC, I was in there for the full day. I arrived at 6 o'clock in the morning and I wasn't able to be operated on until maybe 8 o'clock that night because of other emergencies that came into my hospital. So I was there for quite a long period of time waiting. My husband was allowed to be with me. But at no stage was I given any paperwork. No one discussed with me the type of losses I was having, and no follow-up support at all. And I left with no support system, services, just a literal pat on the back. That was it. And like I said at the start, it's still happening today. A woman I know in my community has had 3 DNCs since February and not one follow-up phone call, not one piece of information given to her, no specialist referrals given to her, and she's a mother of 3. And yeah, it's unacceptable to be in the care of a health. You walk into the hospital thinking that you will be provided with the utmost care and respect, and you left feeling absolutely forgotten. And having any type of loss, whether it's through natural occurrences or IVF, is life-changing, and it does change. And I think it's proof here today that we're still very much affected by these losses. This happened to me 6 years ago and it still deeply affects me today. So I think that shows enough that this is a big problem, an issue that it needs to be addressed.
But it's an equity issue as well. That's how I originally started the herd, because I compared my experience in a private obstetrician's clinic having a miscarriage with that of my peers in rural areas and just went, what is going on? Because that's not what happened to me in any, the care I received was second to none, from ushered from the ultrasound to her room that she cleared, and she gave me bereavement care. I waited 24 hours, had a DNC, and she called me every day for 5 days and provided me resources like Gidget Foundation, Pink Elephant. I was given everything. And so that was how the herd was born, because we saw this. I personally saw the disparity.
Thank you.
Emily, and then is yours follow on from this though? Or, yeah, okay. You're fine, Em? Yep. I'll go to Emily now. Miss Savelle, sorry. It's fine, yeah. I get it. I forget to be formal. So.
That's all right. So do I. Thank you very much to you all for being here and for sharing your own experiences and that of your organisations so authentically. My first question is to Paige. That's all right. I'm just we're on first name basis now, so we'll just continue as we are. But I also feel free for the others to add to this also. And I just wanted to pick up on something you said in your opening remarks about the dreaded phone call, because it's come up previously in evidence that we've heard in the committee, and also through the written submissions. I wondered whether there was anything that you could recommend the committee consider in terms of trying to make that process more human-centred or more human. Yeah.
Yeah. It's a hard one because they have to ring you to tell you yes it worked or not. But I think maybe instead of just they ring you at like any time of the day.
Yeah.
So I was really lucky. I work in the family business. So most of the time, my mum was with me. But my ex-husband couldn't be with me. So a lot of the time, I then had to ring him as well to be like, hey, we've been unsuccessful again. So maybe being able to have a time that you know they're going to ring you. And I know results come in at all different times, but they know that they're going to have to make 5 or 10 or how many phone calls. At least if you can be like, hey, can you ring maybe after 3 o'clock? So then at least my husband at the time could have been with me and we could have taken that phone call together instead of having to kind of take that burden on yourself. So that's kind of one thing I always used to dread.
Oh, yeah. I can imagine. And at any point, is there a question asked of, is this a good time, or just check, does that come into it at all? Or
They sometimes did, like, oh, can you talk now? Are you like kind of on your own or things so you can take that like for
presumably,
privacy, but
yeah, yep.
not really to actually be like, are you kind of okay to take that phone call to have the results like pretty much given to you? And maybe, and I know it's not maybe as personal and I don't know what you would think, but maybe even having the option to maybe not have a phone call and maybe have it written to you in an email or a message, because and at least you're on the phone and they're telling you and you have to kind of pretend that yes you're okay, but you're not okay.
No, yeah.
So maybe actually having that email, so then if your partner isn't with you, you can kind of open it together later. Or it could actually then have maybe information in it that if you do need support or things, and maybe ring this number for counselling, or maybe just a little bit different. And I think for me that would have been better, maybe in emails that we could have opened together and not have to be that brave person on the phone call. Because for me, when I was 22. So I remember sitting on my bed, being this brave 22-year-old, getting the phone call and being told, just tell us when you want to come back in and we'll try again. And I remember we had this timber bed and I remember hitting the timber and dropping to the ground, crying my eyes out and went, I have to somehow pick myself off the floor. And that was probably the first hardest one, and then they got easier because we did 2 each year minimum. So you just got a thick skin and you kind of but at the start of those, I think if I could have been able to cope with it with an email or something, it might have been a bit easier than having to listen to someone and yeah.
Yeah. I'm not sure if others had anything to contribute.
I think those are great options as long as they're presented as a choice would
Yeah.
be my thing to it. That and the choice as well as if it is at 3, which is great because then the woman could tell her work, I've got an appointment this afternoon. Can I have the afternoon off or whatever, without disclosing exactly what it is?
Yep.
But when presenting it, that it is a choice to have it via email, phone, and leave that up to the woman to decide.
I was going to say the primary contact or the primary patient being the woman and
Yeah.
them always being the deliverer of the information to their partners, whoever that may be. I think maybe even just a way in which to navigate that you're not the person to receive that information. Maybe your mum is, maybe your husband is, I don't know, but maybe even just a pathway to designate somebody else to receive that information and them to be the messenger.
I guess if I can put the question back to you in another way, or what I'm hearing is you're saying the importance of having choice and autonomy over that and control over that in terms of how that works for you. Is that the right sort of characterisation, do you think?
Choice and control is the number one protective factor for trauma, isn't it? Like if people feel like they're self-determinate and determining their pathway themselves and what's happening to them, then they're less likely to be traumatized from the information.
A choice with explanation as well. So if it's via email, obviously there's no personal touch with that. So you'll be reading X, Y, or Z. But, and the same with a phone call, though, you might be feeling at the end of the phone call that you have to put a brave face on. So give that choice, but the reasons why there are different choices there, so then they can make a sound decision of what to do.
Thank you. Sorry, did anyone else have anything to add before I move on to my question?
Yeah, just one other thing. I think getting that choice is good, but then also having that person be empathetic on the other end of the phone and saying, are you okay? If you're not, here are the services that might be available to you. And having that choice, whether that's in an email or in a phone call, is good, but having that person perhaps being a little bit more empathetic and not, I know they're a business as well and they've got to operate as a business, but being empathetic, the other person on the end of the phone is not necessarily going to take the news you're about to give well.
It sort of leads nicely into my next question, which was around I think it's mentioned in all of your submissions, the importance of having follow-on or referral on to mental health supports, and that being part of a process I think, Claire, you spoke about earlier in your remarks. I wanted to ask you a bit more about that in particular, but also your thoughts around telehealth versus not telehealth as an option, and what are those options that work best in the communities? Because there does seem to be a difference of views around telehealth in some of the submissions that I've seen. So I'm keen to hear your thoughts on that. Just throw it out there. Anyone wants to say?
Okay, I'll start. So I had to, when I was 6 months down the road after my first D&C, I sought help through my GP. And at that stage, I wasn't pregnant. So I asked, do I need to be on medication? I wasn't depressed, but I was suffering from severe anxiety and sadness. And I went to see a psychologist, and throughout those sessions, I was also diagnosed with PTSD, and then I fell pregnant with Jimmy, my second-born son. So I learnt a lot from seeing the psychologist around my anxieties and why I had it actually really helped my brain understand why I was behaving, I suppose, or feeling the way that I was feeling. In saying that, though, I've done a lot of work after Jimmy was born with women in my community, and a lot of them do like the thought of also seeing a therapist. And again, I think it comes down to choice to the woman between seeing both or either or. And the holistic approach as well, because it does affect your mind, body and soul, what happens to you. So I think all of that put together, again, I think it just comes down to choice with seeing who you want to see. Both psychologists and a therapist, to me, really benefit me. In regards to telehealth, again, I didn't have any of this when I went through my losses, but I think I would have much rather seen someone face to face. When I did see a psychologist, it was clinical, it was bright lights. I was sitting amongst people who were having couple therapy, going through divorce, where I had to go. It was almost in the smack bang middle of town, so people could see you walking in and out. I was worried about people thinking I was me and my husband were fighting or something. And it just felt very, not that maternal hug you still need even while you're suffering losses. You kind of want to sit down and have that more intimate conversation with someone. But like I said, the help I did get in regards to my anxiety and where they stem from, that really did help my brain understand what I was going through.
But you had to seek that out yourself. That wasn't part of it.
Definitely. I had to fill in a assessment form at my GP and I guess be assessed to see how the severity was. And then when I did see the psychologist, I was given 6 free services. But by my 3rd visit, my psychologist had a personal incident herself, and I was told I would get a phone call to rebook, and I never received that phone call. So I actually depended on a really good friend to talk to, and of course my husband. And my husband's a farmer, typical male. He kind of just sits without giving too much back to me. But they were my support network, and I was left alone basically to survive.
Oh, Jen? No. Well, we have a very strong opinion about it.
You go first, I'll go next.
Well, at the Herd, we believe in rich, prosperous, surviving regional, rural, remote communities, and that means we need our services in our areas. I think there is a great deal of fatigue with telehealth services, and we will use it, and when I say we, regional, rural, remote people will use it where it's needed, but I think we need to look at investing in our communities, because for every health dollar that is spent with a local clinician, she goes downstairs and buys her local coffee, but also, you know, I do this every day. Like, I'm more likely to take the crisis call. I'm more likely to work late because it's my community and I want to see them do better. I think that my research in particular with the universities is deeply exploring the roles of perinatal social workers and designated roles both internally and externally of perinatal social workers. So, for instance, like, you might come for mental health, right? And you're sitting there and you're really struggling with the fertility treatment stuff. But actually, the number one thing that's a barrier for you at the moment that's causing you stress is the financial burden. And I can hear that as a person. And I'm like, let's physically sit here together and do the IPTAS form. So all you got to do is get it signed. I've actually unburdened that woman of that. I can't say that that's the same kind of delivery model that you get from a telehealth perspective. So we like to see prosperous rural communities, and the only way to do that is to invest back in them. And telehealth, unfortunately, seems to go back to a hub.
But also to living in regional, rural and remote areas, you need a stable connection to be able to do telehealth. And quite often that's a barrier in itself, which adds another level onto the services is unstable internet connections or mobile services. So it's
And
just
let's be
another
frank, I could be doing an outreach clinic at Inverell and there's still women travelling up to an hour and a half to see me there.
Yeah.
exactly.
Yeah.
So, yeah.
Yeah, I think one one piece we recently invested in around Murrumbidgee Local Health District was a trained nurse who travelled around all the maternity sites to deliver a specific trauma-informed training for all the midwives across the local health district. But then the secondary aspect that she offered for them was a telehealth to her around that trauma-informed piece. So it's a second step. She's gone to them face-to-face first, and now she's available for midwives across that district through telehealth. I don't know if it's like, I have to look into the specifics, but she has made herself available, and the midwives feel well supported with that process piece.
What a fantastic initiative.
I think also telehealth is not for everyone, and not everyone finds it beneficial. However, exploring some of the hybrid systems speaks to the importance of continuity of care and individualised care for women and their families, just in terms of having that point of contact so that somebody can be sitting with you as you approach that care, whether it be in the virtual environment or face-to-face. I think that it's really important to have that continuity model in place.
I think, did you have a couple more?
I have one very specific question for the CWA from your written submission, and I appreciate this may need to be taken on notice. There's a specific comment about the Victoria 2019 Assisted Reproductive Technology Law Reform, and that did better than the New South Wales 2024 review in terms of incorporating regional service expansion. So I'm interested to understand specifically what they did in Victoria that you're asking us to look.
I'll have to take that under notice.
No problem.
That's fine. I'll just keeping with the CWA, again in your submission, I think you talk about, and it sort of touches on what Jen said before about helping people with their IPTAS forms, but just that broader issue of financial reimbursement for travel for these services. And I think Gyra Branch, in your submission, you talk about a motion that they had basically just looking for targeted financial support mechanisms for women who have to travel to access fertility treatment. I guess from your members and from your own lived experiences as well, how important would it be to have additional sort of funding and financial support for that travel piece?
Extremely important. I know when I was first diagnosed, endometriosis wasn't classed as a disease. Therefore, I wasn't entitled to get, or eligible, sorry, entitled's not the right word, eligible to undertake IPTAS to be able to travel. So I had to do it at my own expense. But maybe Paige could speak to it.
I know travel, there's already a cost with IVF, the medication, and then you add being away, accommodation, and then you got your travel. For us, we drove all the way down to Sydney, and you're there for 2 weeks. It's not like you can just pop home and that. So having that allowance or have financial help for travel, even for me with my endometriosis, I actually have to drive 2 hours to see my gynecologist. I'm hoping when the new freeway will go a little bit shorter to Coffs. And then for my operations, I actually have to go down to Port Macquarie because Coffs Harbour doesn't have the right equipment that Port Macquarie Private Hospital has. And I think one other thing is you've got, and I never even knew about this when I was starting my journey, was there's the public IVF, what costs so much less compared to your private, but having endometriosis and things like that makes it that you can't even access. So I actually tried to see, because I had a friend And she saw the same doctor as me.
Mm.
I paid $20,000. She paid $1,000.
Yeah.
Same doctor, but it was through the public and she had no problems. They'd just been trying for a year, so they qualified. They could do $1,000.
Mm.
But because of my severe endometriosis and my adenomyosis,
Mm.
I had to go through the private, and it takes a toll.
Mm.
So even opening up that public and looking at that side, so then at least with transport and all that, it kind of balances it out.
Mm. Do you, like from the women and families you work with, Jen, the sort of cost and the travel
I was
component?
just thinking, like 2 years ago, one of the IVF clinics, one of the private clinics, put out this research that they'd done themselves that said that no woman in New South Wales had to travel further than 100 kilometres, and it was in the response to a story out of South Australia. And I just thought, what a spit in the face to every rural person who has lined your pockets. I just think that private sector can be held so much more accountable. Like when you're looking at continuity of care and how much they're making and the Medicare rebates, it's honestly a joke.
Mm. Mm.
Can I ask
Yeah, sure. Yep.
if that's all right?
Please.
To Paige, in terms of the reasons that you were given for not being able to be seen through the public clinic.
Was because of my severe endometriosis and because of my adenomyosis, I had to, when you do egg retrieval, they put you under.
Yeah.
But when they put the egg or the embryo back in, normally they do that in the clinic.
Yeah.
I have to go and be put under
Okay.
because of my adenomyosis,
Yeah.
and that was why they said no.
Wow.
Mm.
So it was an exclusionary
Yeah.
criteria for them.
Yeah.
And do you know if that's still the case for public clinics and whether that's all public clinics?
I don't know.
Okay, that might be something I'm better put.
I think in those public clinics, when you're selecting a specialist, some of them are endocrinologists and some of them are surgeons, and there's some complications around hospital rights as well, and whether or not what you can access, where you can access, and what's funded. That
Would
might
all
be.
of you agree that there is a need, or there would be a benefit from additional options in terms of those public clinics?
Absolutely.
Mm.
Right.
Again, it's
Can I just
about
note
choice.
that everybody is
Everyone
nodding,
nods,
because the
yeah.
hand side ones did that.
Yes. Yeah, yes. Yeah.
Thanks. Good pick up.
That's
No,
okay.
that was my.
We've got a couple more minutes if
thank
anyone.
you.
I do have another one, but I don't want to take.
Sorry. Yeah.
Everyone else.
I know
I think
the New
someone just
South.
wanted to comment in response.
Oh, yep.
I know the New South Wales government has done a lot to try and clean up IPTAS forms. They're still a nightmare, and I actually think the doctors need some training around who signs what. My GP will sign anything I put in front of her because she knows that I've read a million things in order to be able to know that that's the right thing that she needs to do. And she often tells me she learns a lot from me, and then she says who's billing who for the Medicare, which is the running joke between us. But genuinely, most of the women I see for mental health reasons who have usually got perinatal anxiety are needing me to clean up things like that. And I think it'd be really easy to, where's Rainscock? And they put out a thing and train everybody to say, the OB signs this, the fertility specialist signs it when it's this, and the GP signs it when it's this. Just clean it up.
So I was going to ask probably both to Jen and Claire, but Claire, you talked about rainbow clinics, and obviously that's in the UK, and I had a chance to visit one in New York last year as well, and just having that model where people don't have to come in and tell their story, and it's that really patient-focused care, I think is a really good one. And Jen, you talked a bit personally about sort of your anxiety with your son having been through loss and that making your sort of subsequent pregnancy, I guess, a bit more challenging because you're always a bit on edge. Do you think that, and this is sort of a little bit outside of what we've been talking about, but you did talk about it in your submission, some of the challenges, particularly at the moment, about access to maternity services in some of our regional communities that are getting harder and harder for women to be able to birth in their local hospital and having to travel further and uncertainty. How do you think that all compounds with people who are going through a fertility journey as well? So not only the anxiety of falling pregnant and hoping that it's a successful pregnancy, but then when you get to the birthing end and being in the ward, having that rainbow clinic model or having local delivery options and not having to have the anxiety of potential travel. How does that all kind of factor into what women go through and families as well? And I'm happy for both of you to answer.
Hugely. Well, we talked in our submission about
Yeah.
the recent data that had been released to the UK about the significant portion of women who are leaving fertility treatment with trauma. And that wasn't without layering any of this with regional, rural, remote and the complexities that those women face as well. So I think we could say safely that those numbers or trauma numbers would be higher for those population groups. Then I think women think, well, I've done the fight, I'm pregnant. That's the easy part. And I think Kira talked about this really, really well, particularly within the public system, because that is really the only option rural, regional, remote women have. Let's be frank, in New South Wales, there's a few private hospitals left, but they're few and far between that do deliveries, unless you're prepared to travel like Soph, is that you don't get picked up until 18 weeks. And there's a huge amount. You've had somebody who is up you every week, checking in on you, blood test scans, results. You've been medicalised in a way, and then you're asked to hold space for 18 weeks. You can't get into a GP for 6 weeks. We hear women talk about how they can't get into their ultrasounds. There's a massive shortage on that. They find out finally they were meant to have the ultrasound, particularly in first pregnancies. We've closed 50% of rural maternity services. And this is why I'm really strong on these telehealth models and saying about the investiture back in regional, rural, remote places, because if it is a breed them, train them, keep them model, if we lose our regional, rural, remote maternity services, then what happens? Does that slowly erode the identity of individuals and what brings them back to rural communities and makes us sustainable? So it's not just oh, well, you can't have a baby here anymore. I think it compounds the trauma. So if you're entering, I mean, you guys know from the birth trauma inquiry, you and Emma were on it, and I just can't imagine what that was like. But we know exponentially we have some of the highest birth trauma rates, globally, sorry. And so if you're already exiting fertility treatment with trauma or miscarriage treatment with trauma and you're entering a pregnancy and then services are non-existent, if all not closed, the outcomes are diabolical.
Do you want to add anything, Claire? Or?
I guess just from a personal point of view with experiencing it, I had to, if there was a service available like a rainbow clinic where instead of going to a public space to go and have my scan to make sure that Jimmy was viable, instead of sitting in that space alongside someone with a broken arm or someone who's, I'm not sitting there with a smile on my face. I'm raging anxiety. I actually had a panic attack driving there by myself. My husband met me there, but I had to drive from my property to the hospital, or actually it was a private clinic. But if I had access to scans, or checkups in a space where other women are sitting there alongside me who are experiencing the same thing, or I'm not sitting next to someone I know, because again, in regional rural areas, we mostly know people who are walking in and out of these spaces. So if there was something like that available, it would just reduce that amount of anxiety or worry. And particularly too, again, if it's before 20 weeks, a lot of the time we're not telling a lot of people that we are pregnant. And so just having a safe space to be able to know in that appointment whether that baby is viable or not, and then walking out and being able to get straight into your car without going through all the other different departments of the hospital or seeing someone you might know would definitely 100% help with that internal.
And that's why we're so firm, the herd, on, you owe a duty of care to look at EPAS clinics. And what happened from that inquiry and what's happened since. I mean, Claire just used the words baby is viable, and I have so much trauma around those words because I had kidney stones at 18 weeks and the sonographer was teaching another sonographer and he was being very kind and polite and telling me about the baby, and the sonographer teaching him leant over and he said, all they need to know is that there was a viable baby at the point that you scanned that woman. There's just no sensitivity. And I can understand that they've got a lot to get through. Like, as a person who works in the system, I get it, but yeah.
That takes us slightly over time, but thank you to all of you for appearing today and for your evidence, and it's been very beneficial. There were a couple of questions that were taken on notice, and we might have a few follow-ups potentially for you. So if that's the case, the Secretariat will be in touch. But once again, thank you, and that concludes our hearing for today.